All right, we will go ahead and get started. It's the top of the hour. My name is Kathy Wibberly, and I'm Director of the Mid-Atlantic Telehealth Resource Center. I want to welcome you to the latest presentation in the National Telehealth Resource Center webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. This webinar is also serving as session number 2 for the HRSA Telehealth Learning Series. Webinar topics for the HRSA series include using telehealth technology to address the opioid use-misuse epidemic, using telehealth to manage chronic conditions, including childhood obesity, distance learning, and school telehealth. Just a few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. And any questions that we are not able to get to, we will respond and provide those answers afterwards. Also, today's webinar is being recorded, and you'll be able to access today's and past webinars on the National TRC YouTube channel. Today's webinar, School-Based Telehealth Networks, Lessons from the Field, is hosted by the Mid-Atlantic Telehealth Resource Center and presented by representatives from 3 HRSA School-Based Health Network Grant Programs. These representatives include Jane Hamilton, Katy, Cristaldi, Monique, Vallabhan, and Kevin Werling. The objective of today's session is for you, the viewer, to become familiar with the successes, challenges, and lessons learned from 3 federally funded School-Based Telehealth Network Grant Program grantees as they approach completion of the 2nd year of their 4-year grant-funded initiative. It's my pleasure to introduce Jane Hamilton to get us started.
Good afternoon. Thank you, Kathy. We're thrilled to be able to share our story and anxious to hear everybody else's stories. So I always find people to kind of share. Do I have this now, Kathy? Kathy, I'm not.
You should have mouse control. You need to just accept that control.
Oh dear. No, I'm sorry. Can you do that again? Oh. Do you want to just advance my slides?
I can advance your slides for you. Go ahead.
Okay, go ahead. You can go to the first slide. I always feel it's worthwhile to kind of give everybody a reference of where we're speaking from. So we are located in upstate New York. You can see that lighter gray area is our service area, and the highlighted map and the circle next to it, all the gold dots represent our school-based health center schools. So we're in 15 different school districts in 20 different locations. Some of our school districts have more than 1 school. 14 of our school districts were funded under the HRSA grant. The one farthest to the east does not have a rural designation, so that did not count. So go ahead. Next. Here. And I always make the distinction for those not from New York that we look much more like the top picture than the bottom. A lot of people, when we say we're from New York, they think the Statue of Liberty lives in our backyard, but we're a long ways from the Statue of Liberty. So it's a good evidence why telemedicine is really a right match for our program. Go ahead. So, when we first started this, we really explored, what is telehealth? And I recently had the privilege of spending a morning with Dr. Nirav Shah, who was the COO and clinical vice president of Kaiser Permanente. And he reminded me that, we all like to talk about all the fancy have and how we're connecting and connectivity, but it can be as simple as a phone call, and I thought there was some real wisdom to that. So we're really looking at providing both clinical health services, which we're going to talk about in a little while, but also some health education related services, public health stuff, administrative stuff, and we're starting to use it on all of those levels. So go ahead. So again, phone calls, teleconferencing, video conferencing. We've been doing some of that actually for a number of years before the grant. I think we've gotten a little more sophisticated with some of that. The store and forward imaging, I'm going to talk a little bit about in our dental program. Obviously live streaming and wireless communication. All of these can present us with some challenges though, and we'll talk about that. But being in a rural community with not the best of broadband and connectivity, it isn't quite as simple as we thought it was going to be when we started. Go ahead. So, you know, one of the things, we continually use these two terms interchangeably and really thought, can they really be used interchangeably, or are they different, telehealth versus telemedicine? So I think and as my note says at the bottom, I think most people do use them interchangeably, but WHO does have a little bit of distinction between the two. I would say we're doing more medicine right now, but doing a little bit of telehealth. So go ahead. I just thought some of this was a little framework. So our beginnings with telehealth started a number of years ago, and the New York State Department of Education developed some concussion guidelines for schools. And in those guidelines, it was very clear that a physician, not an advanced practice clinician, but a physician, needed to be part of the clearance process. And our physicians are only on site at our school-based health centers once a month. So that meant there could be a big, long delay before kids could be re-engaged into their activities. We have advanced practice clinicians on a daily basis. So our organization was using some video phones, and so that is really when we first started with what we call telemedicine today, is we were literally calling up a pediatrician from one of our sites on that video phone, which has a small screen, and would be able to accomplish what we needed, in that they could do a brief neuro exam, mental status, with the assistance of the advanced practice clinician. So it was pretty low tech, but it was really our beginnings. Go ahead. The next, the other piece that we've been doing for a number of years is pulmonary functioning or spirometry testing. And we have trained nurses on site that use portable equipment, and they travel around to all 20 sites, but then they transmit those tests to a pulmonologist on our home campus, who then interprets them and sends back. So again, a little different than what we're doing now, but it definitely was, as we look back, it was a part of our beginning in the telehealth realm. Go ahead. So our current project, which was funded under HRSA, really had initially 5 different areas, and we 6. So dietary counseling, psychiatry, primary care, pulmonology, endocrinology, and dentistry. And I'll just spend just a minute or two on each one of them. Go ahead, next. The dietary counseling, we have a registered dietitian that works on our team, and she does travel around to sites, but she only is at each site 1 day a month. Obviously, she goes to 20 sites, and there's basically 20 days a month she can be out there. But there's times that the kids can't get out of class, or they're absent that day, or a parent may not be able to come in and join them. So when she's back in her office, or she may be at another school-based health center site, she can dial into the site where the patient needs to be seen. This is really where we started with this project. We did run into some bumps along the way. Actually, some of our connectivity continues to be our biggest bump. We've purchased teaching aids that are at each site that get kind of pulled out and set up so the kids can handle, an artificial piece of what size it is, and she kind of has the same materials at her desk potentially. So it's worked pretty well because she's been able to see some kids a little more frequently. She's been able to see kids when they may have missed an appointment, and our dream in this, and where we hope to go in the next year or two, is to be able to do some groups. And we kind of thought kids, especially that maybe they're tech obesity issue, if doing a group with somebody you're going to see in math class might be a little tough, but if you're going to be in a group with a kid that's in a school district 3 school districts away and you're probably never going to see them, it might be a little bit more comfortable. So we're looking forward to giving that a try. Next. Telepsychiatry is one of the pieces we've really just gotten going. We do have a child psychiatrist at our medical center that is our base, but he is the only child psychiatrist for 9 counties. So when you remember what that map looked like, he was really the only one to be able to provide those services. So we do a screening with our clinical social workers that are on site, and then once they and the APC decide it's a good solid referral to the psychiatrist, we make that appointment. He has carved out 1 morning a week just to care for our patients, and all of those visits are taken care of and set up through our coordinator, which we did hire a telemedicine coordinator right at the beginning of the project, and that really has been critical to smooth and ongoing operations. Basically, telepsychiatry is for medication management. As I said, we have licensed clinical social workers full-time at all of our sites, so they really are doing the day-to-day counseling and are supported by our advanced practice clinicians. We think the psychiatrist will probably be seeing most kids every 4 to 6 months. So, next. The two of the pieces we haven't quite got off the ground yet are pediatric pulmonology and endocrinology, and we'll be partnering with the University of Rochester. University of Rochester is about 3 to 4 hours from some of our sites. They are very excited to be part of that. Our stumbling block is really kind of some back of the house kind of details that we're getting worked out. For kids to see the specialist, they definitely have to travel no less than an hour and a half from any of our sites. So we're really looking for those kids with asthma that we're just not able to get a handle on. And in general, we do a pretty good job with that, but there always are a handful we're really struggling with. Endocrinology, some diabetes, some other kind of endocrine issues we think that they'll be very helpful with. Both chiefs of those specialty areas were very enthusiastic to partner with us, so we're quite excited about that. Next. Teledentistry. We've been a recipient of a number of grants, and we had one of the childhood oral health projects from HRSA a couple of years ago, and now we've kind of taken it to the next step. And, you know, we all were wondering, what did teledentistry mean? The way we're going to use it is we'll be our dentist who provides restorative care on site. It's just impossible for her to keep up and then continue to, she can complete treatment plans on students, but then to do the every 6-month follow-up. So we'll be equipping our dental hygienist with a Nomad, so portable radiograph that she'll be able to take radiographs and intraoral photographs at the remote sites and send them to the dentist kind of at that 6-month interval. The dentist will then be able to say with the hygienist assessment, this looks good, I'll see them hands-on in 6 months, or I better get them in now. Again, the travel is, you know, even when I say it's an hour and a half, it's a tough hour and a half of lots of hills, lots of mountains, not great road, and then we have winter here. So next. The current, this was our add-on, and we've recently added teleprimary care. So we were doing that concussion clearance thing. You really see the need. We have some very small schools with less than 300 kids pre-K through 12, and so it is not even, you know, cost-effective to have nurse practitioner or a physician assistant there all day, every day, but we do have support staff there. So we're looking to do both a treatment of some acute illnesses and manage of chronic illnesses when we don't have those advanced practice clinicians there with the use of some of our pediatricians. Next slide, please. So the primary care visits would only be done when we don't have a primary care person there. The patient would really be roomed and prepared by our support staff that we're in a training phase right now. And then they would really be able to help present the patient to the accepting pediatrician. Next. We feel that with the chronic management of chronic illnesses, there really are 3 or 4 diagnoses or type of patients that we could easily follow. Those with ADHD, and that means that the staff at the site would have gotten all the Vanderbilts and any other important documentation they need beforehand. And many of these kids are really followed by our pediatricians. We have 2 full-time pediatricians that work up with our program and then 2 part-time ones. So sometimes follow-ups to get that all done during their travels is tough, and this will be a little bit easier. Also be able to follow up on kids with depression and some of the obesity follow-ups that we usually see those kids about every 3 months. Next. The acute care we started back here. The different kind of chief complaints we'll be working on are ear pain, the sore throats, coughs, and concussion clearances. We have purchased and have, again, starting training on the stethoscopes and otoscopes. All of our support staff is able to do point of care testing, so that won't be an issue if it's a kind of a sore throat, we need a strep test done, they can do it on site, and then the receiving pediatrician can develop a treatment plan. Next. The challenges were things we didn't, some we thought we were going to encounter and some we didn't. The connectivity has been a big deal, and we really didn't realize it, but we really knew we needed to solve this problem. So our IT staff has really been very involved in the project, and we are changing our connectivity, so we're not going to be going through the schools kind of server. We're hardwiring in fiber to all the schools. Now, the communication with the schools has been a challenge. Some of them think this is a great idea, other ones don't. So it's taken quite a bit of hand-holding. Acquisition of a long time in our organization. It can take anywhere up to 12 weeks to get a computer. So that definitely is something we kind of now think ahead a little bit farther. Staff training, our staff is spread around 4 counties and getting the training out there. The credentialing of practitioners outside of our organization is really one of the barriers we're running into with, or challenges, I should say. We're going to be able to get through it. Not really a barrier with University of Rochester. Our organization is required that there are fully credentialed practitioners. You know, and it's interesting of getting both our staff and our patients used to this phenomenon of doing this over the wires. I think the visits we've done, people have been very satisfied with. We're in the process of developing some satisfaction surveys, both for our patients and providers, because we really want to kind of quantify some of that and act on that. So next, I think we're about done. Next. There we go. So overall, and we keep telling our staff this, the purpose of all of this isn't to get all this fancy equipment, it's to increase access to healthcare. And when we're sending kids 3 and 4 hours away, families that don't have cars, they don't have gas, they live with grandma who hasn't ever driven out of the county. And the specialty centers are really in cities. You know, they may be small cities, but that's very scary to some of our families. So we really think we're going to be able to meet those needs and increase the access. Next, my contact information. Thank you.
All right, Katy, you should be able to control the slides.
Wonderful. Thank you, everyone. Well, my name is Katy Cristaldi, and I'm the medical director for school-based health here at the Medical University of South Carolina, which is housed within the Center of Telehealth here. Let's see. There we go. And just as a little bit of background, MUSC is a major academic medical center here in Charleston, South Carolina, and we have had telehealth services now for over a decade. The South Carolina State Legislature has taken an interest in telehealth as a way to combat the healthcare disparities in our particularly rural state. And so to date, they have funded telehealth programming through the Medical University of South Carolina for the state, with some generous state appropriations. These appropriations also helped create the South Carolina Telehealth Alliance, which is a consortium of all of the major healthcare systems within the state, as well as state agencies and other partners that have really come together to think about the most effective way to improve health of South Carolinians through telehealth. And just a little bit of background on our school-based telehealth program. We also had a existing in-person traditional school-based health model here in Charleston for the last, over 20 years now. And in 2014, a young pediatrician here thought, that there should be a way to kind of extend the benefits of these programs to our more rural areas in the state. And so he piloted in one local urban school and 2 schools in a particularly rural county that at the time had no pediatric care whatsoever. Now we've grown to support over 80 schools throughout the state. We do that as the providers here at MUSC, connecting to those schools, but also in support of local providers. So more and more now we are equipping schools and local providers and providing the training and support needed for local providers to see their own patients located in the schools. That's, of course, necessitated the growth of our team to support that kind of network. And so I serve as the medical director for the program. We also have a lead nurse practitioner, a manager, as well as support staff. I don't think most people need really to go into a lot of detail on this slide about what is school-based telehealth. Jane did a great job kind of parsing out telehealth and telemedicine. But we use secure HIPAA-compliant video conferencing with electronic peripheral stethoscopes, otoscopes, and exam camera to treat children as they would in a regular clinical setting. We provide in our program acute care, sick visits for most low acuity common illnesses of childhood, as well as some chronic disease management for asthma, ADHD, and we provide some specialty mental health services, particularly trauma-focused cognitive behavioral therapy for children who have experienced a traumatic event or have symptoms of PTSD. I thought that I might spend the rest of the time kind of thinking about how we've scaled this program and the internal framework we've used to think about large-scale implementation. So we've been using an adaptation of an IT-based framework that we, as a Center for Telehealth, adapted to telehealth program implementation. And it has several strategies, several phases, which I thought we might just walk through right here. So phase 1 is really the strategy phase, and in the very early stages of implementation of the program, when the state said, we think this is good, we'd like to fund an expansion throughout the state, we thought about, well, what should the strategy for that be? And what we've tried to do is say, how can we reduce healthcare disparities, educational disparities, and hopefully have some kind of return on investment, whether that's a direct return on investment or looking at how we've changed healthcare utilization patterns from very expensive utilization patterns to less expensive utilization through increased access to this kind of acute care and chronic disease management. And so these two photos, or these two graphics, are showing where in the state the Department of Education highlighted they felt like there were large educational disparities. And then the bottom photograph shows ED utilization rates for childhood asthma. And unsurprisingly, the red areas are that rates of highest utilization. And you can see that these two maps really line up pretty well. Oops, I'm sorry. In the next kind of strategy phase, once we thought about, okay, well, where could this program be the most useful? We then start having conversations with those school districts. And I'll say initially it was us approaching school districts, and more now those school districts are approaching us. So we usually set up an initial meeting and to explore kind of the idea, what that setup might look like in that local community, really engaging the lead nurse as early as possible. And then we also ask at that point if there's a relationship with a local provider, and we try and bring that local provider in as early as possible. We then have some follow-up meetings. Often we're asked to present to the school board for approval. And like I said, we really try and get that buy-in from the school nurse as early as possible. We've partnered with the South Carolina Department of Education to develop consent forms and agreements or contracts with school districts in order to really make it as comfortable as possible for everyone involved. And I don't know if the 4-page consent form is what you would call comfortable, but it's what everyone's attorneys felt comfortable with. So that's what we have, is a consent form that's both a consent to treat and covers both HIPAA and FORHP. Sorry, I'm having a little bit of trouble with advancement of the slides. There we go. In the next phase, we think about equipment and really what the design of the program is going to look like. We send IT professionals out to every school district to work with the school district IT representative to secure the right amount, make sure there's enough bandwidth to supplement that if necessary, provide data circuits, think about firewall management. Things that we've learned over time can be barriers to getting the program off the ground. We make sure we have the right equipment for that space, and then go ahead and order and install the equipment. In that next phase, we think about as kind of the transition phase once we've set up the program, really making sure that we have everyone trained and ready to go. We do a lot of intensive training is done by our lead nurse practitioner with those school nurses, really talking them through the consent process, documentation. I will say here in South Carolina, South Carolina Medicaid covers the professional billing for these services, but also, I'm sorry, I'm not exactly sure. Sometimes it's advancing without me. But it also, let's see if I can go back. Well, I'll just say that the last slide was really about training school nurses. We train the school nurses in how to support their own billing. They can bill a facility fee that matches the professional fee. So we help train them on how to best do that in conjunction with the Department of Education and South Carolina Medicaid. And then also how to best use the telehealth equipment. We also do intensive training with the local providers, sort of the same kind of process, talking about consent, documentation, billing of South Carolina Medicaid, and then how to best kind of fit this into their own office workflow. All right. And then we do a number of mock calls with those nurses and local providers, because we don't ever want anyone to feel uncomfortable with the use of equipment. The more we've done these mock calls, and even at different intervals done additional mock calls, people have felt more comfortable with the equipment, and we've seen increased utilization. And then we're really ready for the clinical launch part, and that, while is the exciting part and really is the meat and potatoes of what we're trying to do here, I think it's just really important to think about all of those preparations and all of the phases that come before this. That's really the biggest lesson that we've learned, is that the more preparation that you put into it, and kind of anticipating what the barriers might be, the smoother that clinical launch and actual utilization goes. Again, we really thought about in our evaluation of this program that we're increasing access to care. We really wanted to strategically target key populations, so we weren't just increasing healthcare utilization for the sake of utilization, but actually changing utilization patterns. And we added that third graphic, shows sort of to some extent where we've expanded in the state. Then we've looked really at the quality of the program. So we surveyed caregivers who felt overwhelmingly that this was particularly a helpful thing in our for our low-income families, and reduced a lot of stress for both the caregivers and the child, and increased access to more timely care. This was a assessment that we did of our ADHD program, looking at how well we met guidelines compared to our own internal university pediatric practice. I practice in both our telehealth clinics and our pediatric practice here at MUSC, so I can only be so proud of this. But we, I'm sorry, this is missing the key, but the lighter colored bars are our school-based telehealth programs. And we were able to kind of meet the standard for follow-up intervals and use of a standardized scoring tool by both parents and teachers much more efficiently than in our in-person care. Our mental health program, as I said, focuses really on children with traumatic experiences, and is a time-limited treatment program. It's usually about 15 to 20 visits once a week. That can be quite a barrier for children to miss that much school and get to these specialized providers. And so they were able to increase access for quite a few children who did not have access to this type of services, particularly those of racial and ethnic minorities. And in the children seen in our pilot of the program, we had a 97% treatment completion rate, and all of the children who completed the program had resolution of symptoms, which was better than the standard for in-person care. We continue to work on further evaluation. I'm currently working on some particular health outcomes related to asthma, days of symptom control, and whether or not we're achieving optimum dose titration in our ADHD clinics at faster rates than we do in person. Educationally, we've been asked to look at missed school days, at seat time, or are we reducing the amount of actual class time that children are missing in academic attainment. I'd love to hear from anyone else about how the data sharing with school districts has gone. That's been a challenge for us, but one we're currently seeing an end to, so we're excited about that. And of course, kind of the golden egg that we're looking at is also what kind of downstream financial impact there may be, because this is a state-supported program. This is something that our funders are interested in. So looking at really shifting those utilization patterns, preventing missed work and school days, and the kind of downstream direct and indirect cost savings associated with that, and what kind of return on investment the state is really getting. So that's our program in a nutshell, and my information, if anyone might need it.
Okay. We are presenting on facilitating rural opportunities with new technologies and services, also known as Fronteras, Lessons from the Field. I'm Monique Vallabhan, Clinical Assistant Professor and PI on Fronteras, and I'm here with Kevin Werling, our Telehealth Manager. We are from the University of New Mexico, Department of Pediatrics, Division of Adolescent Medicine. Advance the slide, please. We have no conflicts of interest to disclose. Funding was provided by a HRSA Telehealth Network Grant, and we are in year 2 of a 4-year initiative. Background: New Mexico is the 5th largest state in the U.S. 34% of the 2.1 million residents live in rural and frontier areas in 2015, and these people are more greatly impacted by healthcare workforce shortages. We have 55 school-based health centers located throughout New Mexico, and 35 of these are located in healthcare provider shortage areas. School-based health centers provide services that are located in schools and easily accessible. Gaps in existing care in New Mexico. There's high prevalence of abuse in our youth, and at the same time, we have a statewide shortage of behavioral health care providers. Medical nutrition care for chronic disease. We have about 20 registered dietitians throughout the state, and 9 of them work for our university. Only 3 specialize in pediatric care, and there are only 2 pediatric endocrinology practices in the state. Asthma, quality improvement initiatives on training providers in best practice guidelines have been promising. However, reaching providers throughout the state, in particular in rural and frontier areas, have been challenging. Oral health. There is high prevalence of dental disease in rural and low-income families, yet at the same time, these families have lower rates of dental care. There's evidence to suggest a role for rural school-based health center telehealth. School-based health centers are located in medically underserved areas that address the workforce shortages by increasing access and utilization of primary care. The utilization rates are highest in children with public insurance or no insurance. And the greatest impact of school-based health center care is among children with chronic diseases. And you also have an option to increase access to subspecialty care via telehealth in school-based health centers. Telehealth. My colleagues Jane and Katy have already spoken about telehealth and kind of defined that, so I won't go into that. A systematic review of telehealth programs indicate that they are more likely to be economically successful if the focus of the implementation is on the organizational model of care rather than on specific clinical content areas. There's increasing political pressure and an increasing telehealth industry that are both shaping telemedicine guidelines with little medical provider input. Therefore, telehealth partnerships with academic providers are more attractive to protect the patient and the provider interests alike. So we set out to do just that in partnership with HRSA. Our aim was to create a financially sustainable outpatient, direct service, and case consultation telehealth practice needed in school-based health centers in 4 rural New Mexico communities for subspecialty healthcare in the areas of asthma, obesity, diabetes, behavioral health, and oral health. And these are our 5 content areas. Methods. We set out to provide direct service telehealth care, provider-to-provider case consultation, tele-echo, which are short didactic sessions followed by case presentations, and tele-education, which are Moodle didactic sessions on best practice guidelines on the 5 content areas: asthma, obesity, diabetes, behavioral health, and oral health.
Okay, a little bit on our telehealth IT and equipment. We chose to use the Zoom meeting rooms. We have a dedicated room set up for each of our 4 sites that we're working with. We also use those rooms for our coaching calls that we did for the first year. We did that every single week. We also provided some computer equipment, including full setups for some of them, including some add-ons like HD cameras, headsets, and speakerphones. We also provided some USB stethoscopes to each of the sites. This aided in provider buy-in. They really like these stethoscopes. They're electronic. You can increase the volume on them as well as make recordings. We also provided USB otoscope and iScopes, just like Kathryn was speaking of, for primary care via telehealth. We also provided training in person initially, as well as ongoing in-person trainings through telephone and email, and training by doing. So like I said, the coaching calls that we have been doing are also in those same rooms that they'll be using for patient encounters.
This is a timeline with phases of our work on the project. Phase 1 was the site recruitment and enrollment. During this time, we developed content tools and resources for the sites, which included protocols and algorithms. We also began the data collection on site demographics. We also began training the staff on the medical record review for baseline data collection to come in the form of productivity reports in the future. And we administered an electronic readiness assessment to guide the quality improvement process throughout. And this assessment was administered to the staff. Phase 2, initiation. We made our initial site visits at the 4 sites and obtained participation agreements. We began training the staff on quality improvement in telehealth. We developed process and cause and effect mapping to anticipate workflow disruptions and minimize those disruptions. We also began training on development of PDSA. Phase 3, implementation. We obtained data agreements and human subjects approval. We began the coaching calls. We provided technical assistance at the pre-launch, the launch, and ongoing. And we began the data collection in the form of monthly productivity reports and provided feedback to the sites on these reports. We began training, clinical education and training of the providers at the sites through the didactic Moodle sessions, and we looked into developing mechanisms for patient referral, registration, clinic encounter, and billing. Results. There are 3 levels of results: at the organizational level, the telehealth clinic care level, and the revenue level. The red rows across the top of each section represent outcomes of each level, and the pink rows include specifics. At the level of the organization, we obtained data agreements between the site CEOs and our own organization, and this was quite time-consuming. They had many questions. We also experienced staff turnover both at our organizational level and within our internal core team that created some challenges. We also had IRB challenges. They had concerns about the consents and the data agreements. We ultimately obtained IRB approval October 2017. We also had issues and concerns, challenges around direct secure messaging. While the New Mexico Health Information Exchange direct secure messaging platform is available, our own organization was not ready to implement that. So we're using internal eFax, which is where the originating site, our 4 sites will fax the referral and it will come to a secure email here at our location. We also organized an adequate workforce and secured 2 staff from each site dedicated to work on our project. And we experienced challenges around specialty care integration, in particular oral health. Their billing codes are different than our medical CPT codes, and so that is still a work in progress. The second result was at the level of the telehealth clinic care. We received 4 referrals starting in January 2018, 1 canceled, 2 no-shows. We turned one of those no-shows into a provider-to-provider case consultation. We facilitated 1 neurology direct service care through UNM Telehealth, and we had 1 direct patient telehealth care encounter. We began assigning clinical education and training to the site providers through the Moodle sessions beginning in June, and we experienced challenges, as Kathryn spoke about, with the school sites where they were requiring that we could not keep students out longer than 20-minute intervals. So this created particular challenges for behavioral health. They can't do therapy in 15 minutes. And we also found that we have no prescribing providers for behavioral health. The third result was at the revenue level. We determined that additional registration training was required in order for our receivables to go back to the grant index. We also developed our charge ticket, and this was quite time-consuming to identify and organize the CPT codes. And we established our revenue cycle from start to finish, and reimbursement is pending. Discussion. Challenges and barriers. Our biggest challenges early on were the data agreements and IRB, and then after that was the secure information transfer. We are now experiencing low service utilization rates. The rural culture views us as outsiders, and parent buy-in has been low, and that's around mistrust and possibly immigration status. We are a border state with Mexico. We also experienced challenges with site provider workflow demands and labor-intensive technology early on, and billing, coding, and revenue issues. Resolutions and solutions. We recommend early on develop workflows and IT security review, establish revenue, billing, and coding cycle teams, and set up in-person meetings with IRB to anticipate issues and concerns that they may have early on. Begin telehealth provider credentialing and privileges, both at the originating and the distant sites. We recommend in-person site visits, ongoing IT support on demand, and then more recently at the sites, the staff integrated student artwork into flyers about our project to increase awareness of services that we have available. This is an evidence table with data from 3 systematic reviews and 1 qualitative study on telehealth programs and characteristics of programs that are successful. That's not the right one.
I'm trying to get back to the other one.
So it jumped ahead 1 slide, so I'll just continue. The evidence table that was on the previous slide includes data from 3 systematic reviews on telehealth programs and 1 qualitative study. And it identifies characteristics of programs that are successful and those that fail. And also recommendations. The red rows across the top characterize the benefits, successes, criticisms, and failures, and also pearls. Within these categories are 3 main themes. In terms of benefits and successes, number 1, perceived benefits. This is in terms of improved healthcare and the technology usability. 2, training and support. 3, increased patient empowerment and increased patient self-management. Criticisms and failures. 1, technology complexity and frustration with that technology. 2, workflow disruptions. And 3, issues around privacy and security. Pearls. Number 1, telehealth services need to match the needs of the local community. 2, demonstrate benefit of telehealth services. And 3, on-demand support for telehealth. In conclusion, it jumped ahead again.
There we go.
Well, there is a high need for specialty care in rural New Mexico. Providing telehealth care services is possible, but not without challenges. Anticipating, addressing, and implementing organizational level agreements early on is imperative. Telehealth is innovative and novel in rural communities, and it may be met with mistrust, so it's important to establish and maintain relationships. Take steps to minimize the site workflow disruptions, and also provide ongoing on-demand support. Next slide, please. Our next steps. We are working towards increasing referrals. We will initiate quality improvement and process evaluation, and we will begin piloting the Rural Telehealth Research Center data collection measures beginning in September. Thank you for your time, and that concludes our presentation.
Ray, are you going to facilitate the Q&A?
Sure. Hi, everyone. So my name is Ray Dizon, and I'm the project coordinator for the NCTRC. So I'll go ahead and get the Q&A started here. So first question, does Medicaid and SC, I'm guessing South Carolina, cover teledentistry?
Let's see if they apply to us.
Hi, this is Katy Cristaldi. So I am not aware that it does, but I can look further into that question. We have been asked to look at some teledentistry and have some pilot aspects for that, but we don't have a teledentistry program currently within our school-based telehealth program, but I can look into the specifics of Medicaid programs.
All right, so second question. Are you using a Vizia mobile cart and software platform? This might have been a question for Katy.
Sure. So I will say we are vendor agnostic here in South Carolina, and we have used a number of different technologies in our schools. Most recently, in most of our schools currently, we are using a Vizia carts. We also are utilizing their software platform, and we're just in the beginning stages of using that platform for endpoint management and scheduling.
All right, awesome. So next question. How do the school nurses have time to do telemedicine in addition to their daily duties?
I can speak to this from us. In New York State, all of our schools have school nurses. They are hired by the school. We have a school-based health center team, and they're the ones that facilitate, prepare, present, whatever the patients. So we're very separate from the school nurses.
So I'll say in our program, this has been a challenge. I think this is a universal challenge. I don't think most people recognize who don't work in school health the enormous number of patients that a school nurse sees in a day and how busy school nurses are. They're really the frontline public health professionals. In some of our most mature programs, we do utilize an in-county telepresenter who we provide. In our program, they're nurses, many of whom are former school nurses. But we've also encouraged the school nurses to use the equipment and to request visits without a telepresenter. I do think there is a key in making those as efficient for that school nurse as possible. I think Monique had some really interesting challenges with the schools asking them to keep it to 15 minutes or less. That's certainly our goal, but that can be a challenge.
All right, so next question is, are you scheduling appointments or are these walk-ins only?
We're scheduling the appointments, and we receive feedback from the sites that they would like to have on-demand appointments. So we are going to schedule two days a week for a couple of hours where we will be available for walk-ins. We'll be starting that in the next couple of weeks.
So I will say we do a combination. Our acute visits are typically walk-in visits, and our chronic disease management is typically
And most of ours are planned or scheduled. There might be some acutes that walk in, but they would need to be kind of scheduled maybe in a half an hour. But.
Okay, so next question. How do your programs work for those without insurance? Do they have to pay out-of-pocket fees?
No, for our program, they don't.
Ours either.
In our program, we do try and connect the uninsured children to Medicaid, and so we have some dedicated personnel that work on that because we know that the children need some kind of insurance, and so but when we are the providers, we drop a bill. So we contact parents ahead of time if their Medicaid is not active, and we have a self-pay discount. I can't speak for all of the different providers that we support, but what we do is contact parents ahead of time so they make sure that they know whether the visit will be covered.
Okay, so next question is, do these programs require involvement with academic medical centers to provide the clinical consultation to school personnel? What incentives led them to participate?
So we here at the University of New Mexico happen to work for the University of New Mexico. So I don't know, it's naturally set up already. So we are a part of an academic institution. So Jane, Katy, could you all possibly speak to that?
I can say we're sort of in a similar scenario. We were funded by the state to start these programs. We do support the other large healthcare systems in providing care, and then local FQHCs and private practices in providing care as well. I guess from the incentivization piece, when I first started, I could not have begged a local provider to take this on, and now I just ran back to my office for this after a meeting with 3 local providers in one county, and we were kind of hashing out how they could all 3 work together to provide the best, most efficient care possible. So more and more, I think providers are interested in doing it if it's billable in your state.
Okay, so I'm looking at the time. Everyone's asking really great questions, but unfortunately, we are coming close to the hour. The slides and recording of this webinar will be posted to our website at telehealthresourcecenter.org. For those whose questions we didn't get to, please feel free to contact the presenters with your questions, which can be found in the slides. So I'll hand it back to Kathy Wibberley for final statements, and thank you, everyone.
Great, and thank you. This presentation has been part of the National Telehealth Resource Center webinar series. As you'll see on your screen, the next webinar is scheduled for Thursday, July 19th, and will be presented by the Northeast Telehealth Resource Center on innovation and impact with speech-language pathology telepractice. Another issue that is probably relevant to your interest in school-based telehealth. Registration and further information will be sent out soon. In addition, for those of you who are joining us as part of the HRSA Telehealth Learning Series, their next presentation will be August 8th from 2 to 3 p.m., and it's working together to eradicate pediatric obesity. Again, an area of interest for those of you in schools as well. So we really value your opinion and ask that you take a few minutes to complete the online survey. Let us know what we're doing well, what worked well for you, what didn't, and how we can improve. And thank you again for your time, and thank you for those who are presenting with us today.